Okay, hello everyone. My name is Jens König from Münster, and it's my pleasure to welcome you to our today's webinar on autosomal dominant tubulointerstitial kidney diseases. I have the great honor to introduce our today's experts, Christian Scheidler and Professor Jan Halbritter. Christian Scheidler is an ePAG and will present to us the patient's voice and perspective on this topic. He will provide us with some valuable insights into the challenges and obstacles one has to tackle when affected by such a rare kidney disease entity. Subsequently, Professor Halbritter will then give us a systemic overview on what we call ADTKD. Jan Halbritter is a senior nephrologist and the head of the Center for Rare Kidney Diseases at the Charité Berlin University Hospital. After his postgraduate research fellowship in the lab of Friedhelm Hildebrand at Harvard Medical School, he returned to Germany and built up his own working group with a focus on nephrogenetics in Leipzig. And last year, Jan received a Heisenberg Professorship for Genetic Kidney Diseases and moved to Berlin. Professor Halbritter's scientific focus is on the identification of genetic causes for chronic kidney disease, and his achievements in this field made him an internationally renowned expert and a board member of the KDIGO Steering Committee on Genetics in CKD. Jan and Christian, it's a great honor to have you here, and the floor is yours, and we'll start with Christian Scheidler's presentation.
Thank you very much, Jens. Yeah, thanks a lot also from my side. Hello to everybody. Thanks a lot to ERKNet to give us the opportunity. We are as a family touched by ADTKD. I always make the sign because ADTKD, of course, can be easily mixed up with ADPKD, polycystic kidney disease, due to its similar sound. We got the news 4 years ago that we as a family are affected by ADTKD, and we started with setting up our webpage 4 years ago. Later realized that raising awareness for ADTKD is really, really important. Because ADTKD, one sentence to characterize ADTKD is that the phenotype of ADTKD is so unspecific. So ADTKD cannot be diagnosed or easily detected by blood or urinal probes or by ultrasound. The only reliable test is genetic testing. And so there's a great probability that there are much more ADTKD cases outside. But of course, we as patients, we understand as there are more than 200 rare kidney diseases, we cannot expect that every nephrologist knows the disease. So that's why we emphasize our work in raising awareness by going to conferences, by publishing on conferences, like at the German National Annual Nephrology Congress called DGFN, where we had posters last year and this year, and of course also at the ERA, the European Renal Conference. We are also very active in networking. We are very proud to have a very good contact to the American sister organization, Rare Kidney Foundation. The name is a bit misleading. The Rare Kidney Foundation in the US solely is focusing on ADTKD. And through this channel, we get first-hand information about research at ADTKD in the US, which is very promising because in a laboratory, ADTKD could be already treated. There's the work of Anna Greker at the Broad Institute. I guess Jan is touching that a little bit later. I'm personally also involved in the ERKNet organization, which I think is a very, very good organization to tackle rare diseases on a European level. And of course, we support the Charité by their research project, which I guess will be presented later. Yeah, and we emphasize really that you visit our webpage. You can see the URL there. You can just Google it. And these Russian puppets symbolize a family. You know, these Russian puppets which are put together because, of course, inherited diseases, this is always a family story. Jan, could you please go to the next slide? Thanks. So this is our family story. You see the typical family hierarchical tree. You see the typical pattern of an AD disease, of an autosomal dominant disease, which is propagated through the generations and which cannot jump over a generation. And I don't want to go into all details here. I guess you're familiar with it. So the circles stand for female, and the rectangles for males. And by the gray charts, you can see how the disease is propagated. And a very, very important information here is the case in our family, that the variety of the progression of ADTKD is quite great. Like if you look on my wife, she has a relative stable creatinine with 1.2 milligrams, and is more than 50 years old. And my daughter, she's also online today. She's unfortunately already on dialysis. Last slide, please. Yeah, and from our point of view, from a patient's point of view, it is very, very important for us to identify more patients. That is, from our point of view, very, very crucial to show that it's a real relevant disease, to find patients in an early stage. And one special problem of ADTKD, I guess Jan will cover that too later, is that we have several subtypes at ADTKD, and I told you already that gene testing is very, very important. And in our case, as we have the subtype MAC1, the gene testing is very, very difficult because it occurs in the so-called VNTR region. That is an area of the gene which cannot be diagnosed by standard methods like next generation sequencing. And you can find all on European level, all laboratories. So there are only a limited, unfortunately, only a limited number of laboratories, and all European laboratories who are able to do the MAC1 gene test, you can find on our webpage under the Diagnostic tab. And if you would press to the link, you would see this list, which you can see here in small. Please feel free to contact us if there are any questions. We have a great network already in Europe, and we're happy to support physicians and patients anytime. Thanks a lot, and then I would hand over to Jan.
Yeah, thank you very much for the introduction, Jens, and also for providing the perspective of the affected families, Christian. That's very important, and we have been in a very fruitful, I think, and good interaction with the patients' organization led by Christian and his family. I want to give you in the next 30 minutes an overview about ADTKD. And I want to point out that the slides I'm using, they have been made together with Eric Ollinger, who helped me preparing the slides. Unfortunately, he wasn't able to present today, but so I'm put him here, his image here. He's an expert, a long-standing expert on ADTKD, and did a lot of research in Olivier de Voist's lab, who is a leader in the field as well. So I want to start out with the definition of ADTKD, epidemiology, a little bit about the genetic diagnostics and genetic genotype-phenotype correlations, like clinical features, and then finally about therapies. You know, there is no specific therapy licensed today, but we are kind of hopeful that this is going to change in the near future with clinical trials. So when you think about when to suspect a monogenic tubulointerstitial kidney disease, of course, one of the main key criteria that factors in your pre-test probability is the family history. So whether if you have a first-degree relative that has CKD, then there is a high likelihood of a dominant kidney disease, and dominant kidney disease in terms of tubulointerstitial means basically a high likelihood of ADTKD. This score was published a couple of years ago by Laurent Mesnard's group in Paris, and it's still available online. And I think it's a quite useful score to predict pre-test probability in families when you want to run genetic diagnostics. So when do you suspect ADTKD? Well, when you think of inherited chronic kidney diseases, of course, you do urinalysis. If there is no hematuria, no significant proteinuria, then ADTKD is a good guess. So if you have heavy proteinuria, then it's likely not to be ADTKD. You have to think of glomerular diseases. You know, there is genetic forms of FSGS and so on. But if you have a bland urinary sediment, if you have no significant proteinuria, then you should think of tubulointerstitial kidney disease. And then you have a look at the kidney morphology. And of course, if you have large cystic kidneys, this points into the direction of ADPKD. But if you have normal sized, small, rather small kidneys, maybe some minor cysts, but not a cystic image, then it's very likely that there is something like ADTKD going on. I already pointed out the family history is a key criterion. So all tubulointerstitial diseases on the genetic level that are that have healthy parents or non-affected parents, you would rather think of a recessive disorder like nephronophthisis or like ARPKD. But if you have a dominant family pedigree, like a father or mother that is affected, maybe an uncle or an aunt, then you should think of ADTKD. And ADTKD is characterized by tubulointerstitial fibrosis. So you see here these are the tubules, and in the space between, normally there shouldn't be much extracellular matrix, there shouldn't be much fibrosis going on, but here you see that the space in between the tubules, there is a lot of tubulointerstitial fibrosis, and you also see tubular atrophy and sometimes tubular dilations. But this is a very unspecific histological pattern, and it's not specific to ADTKD, it's just tubulointerstitial fibrotic kidney disease. So you definitely need genetic testing for establishing the diagnosis. Christian already mentioned ADTKD is a diagnosis that is made on the genetic level. So you have a family history, you have the absence of specific urinary alterations, and then you don't need to make a biopsy, but if you have a family history, then you would go for genetic diagnostics. And we know, to date, we know at least 5 genes. There's even more. I will show one slide later. But the predominant 2 genes, and that's very important, are UMOD, uromodelin, and MAC1, encoding for mucin-1. So these are by far the 2 dominant ADTKD subtypes. And then there is others like ADTKD HNF1 beta, where there is large controversies right now. What is actually meant by ADTKD HNF1 beta? Because HNF1 beta is associated with a lot of other renal diseases and extrarenal diseases like maturity onset of diabetes of the young, type 5, renal cyst and diabetes syndrome with CACUT, congenital anomalies of the kidney and urinary tract. And it's not well defined for now what is actually meant by ADTKD HNF1 beta. I mean, there was kind of in the initial publication, I will get to this in a minute, it was not fully defined and not as well defined, I would say, as the other subtypes. Then we have ADTKD-REN, which fits well into the ADTKD disease pattern, but is much rarer than MAC1 and UMOD. And we have ADTKD-SEC, 61A1, which also fits into the pattern of ADTKD, but is also a rather rare entity. And if we don't have a genetic diagnosis, but clinical presentation that is reminiscent of ADTKD, usually the term not otherwise specified is used. So NOS, ADTKD NOS. What has been revolutionary at the time when the ADTKD nomenclature was published, that was in 2015, was the unified terminology. So having a disease name like ADTKD that is more like descriptive tubulointerstitial kidney disease with the inheritance pattern hyphen gene. And this unified terminology was very new at the time, and other genetic kidney disease nomenclatures now are starting to follow this example. For instance, in ADPKD in the KDIGO guidelines, which come out in January in Kidney International, they will also follow this terminology with clinical description hyphen gene name. So that has been very progressive at the time, and I think a very useful terminology that is applicable to all kinds of genetic kidney diseases. So if you think of a shared mechanism between, I would say, the most frequent or the most important ADTKD subtypes, it is basically toxic gain of function of the encoded gene products. So uromodulin is exclusively expressed in this tubular segment, which is called TAL, the thick ascending lip of Henle. And uromodulin is the most, as you know, it's secreted into the urine. It's the most abundant protein in the urine. And the problem in ADTKD is that the mutant uromodulin is not fully secreted into the urine. So it's either retained in the ER or it's partially retained there in the ERKNet, so the trafficking pathway to the plasma membrane, but it's definitely not fully secreted to the patient urine. And this is why it causes a toxic gain of function effect intracellular. Similar for mucin 1, this is not restricted to TAL expression. Mucin 1 is expressed in distal tubules, collecting ducts down to the pelvis, so it's more widely expressed. But same as in UMOD, MAC1, once it's mutated, the so-called MAC1 frame shift down here, protein, it's a neoprotein that is somehow retained intracellular and is causing a toxic gain of function effect. So this is reminiscent, or it's comparable in both ADTKD subtypes. With REN is not expressed in the tubular system, but it's expressed in the periglomerular cells. And also in case of ADTKD REN, there is different kind of mutations that overall either cause to an intracellular retention, or they cause defects in even already in the translocon and transmission from the translation to the ER. So that is also a problem of a toxic gain of function disease. And this is shared pathomechanism between all these three entities. The epidemiology, well, there isn't so much data, and we think that ADTKD is still very much underdiagnosed. In these few studies, like the one from Ireland, from Peter Conlon's group, the Irish Kidney Gene Project, we know that in the ESKD population, so the population on dialysis, on kidney replacement therapy, there was about 0.5% of patients with an ADTKD diagnosis upon genetic analysis. When you look at populations that had an a priori suspicion of an inherited kidney disease, this is also data from the Irish Kidney Gene Project, MAC1 was one of the most frequent genetic findings. So here PKD1, of course, as the leading genetic entity, but then MAC1 with almost 9% pretty frequent. And MAC1, Christian already mentioned, is very hard to detect upon conventional genetics. It's impossible, so you need to run specific genetic testing methods, and I will get to this later. In this seminal work by Ali Gharavi's group in 2019 in the New England Journal of Medicine, 3,000 patients with CKD were exome sequenced, and at the time, this was like the first big genetic kidney disease study in an adult CKD population. And it wasn't surprising that PKD1-2 turned out to be most frequent, but it was already very surprising to most of us that the collagen 4A3-5 genes were the second most frequent cause. But then interestingly, UMOD was the next frequent genetic finding, and I have to point out that MAC1 wasn't included here because MAC1 mutations, or the classical MAC1 frameshift, is not detectable with conventional exome sequencing. When you think about UMOD was already kind of frequent, and then you add MAC1, you could make the suspicion that after ADPKD and Alport spectrum, ADTKD is probably the third most common cause of genetic kidney disease. This work is very important because it is the largest genotype-phenotype correlation of an ADTKD cohort. Here, the US registry, 430 families from the US registry from Tony Blair, and 156 families from the Belgio-Swiss registry, that's Olivier de Voist, and Inselspital Bern, that's Daniel Fuster's collection, were pooled together and then screened for UMOD and for MAC1 and on a sequential basis. So first of all, UMOD screening, and then UMOD positive or negative, and then whoever was negative was then followed up by MAC1 screening. And you see here that UMOD, the proportion of ADTKD UMOD was most frequent, 37%, followed by MAC1 with 21%. And there's quite a lot of families that were not genetically solved at the time, but fulfilled the clinical criteria for ADTKD. When you look at the mutational landscape of UMOD, what is very special about UMOD is that nonsense or truncating variants are usually non-pathogenic. So that's very different from a lot of other kidney disease genes that you deal with missense variants in that disease. And these missense variants are majorly cysteine alterations. So cysteine is changed to other amino acids like serine, glycine, arginine, and so on. So 2/3 are cysteine, 1/3 is non-cysteine, and then there's some indels that is most of the time in frame. So truncating mutations are not pathogenic. And the most important exonic hotspots are 3 and 4, and that matches to this N-terminal protein domains. The zona pellucida C-terminal protein domains are usually not that much affected, more tolerant to the disease. There's mutations or pathogenic variants that are more frequent or recurrent. For instance, in the UK, there was this one founder mutation reported in radar. And founder mutations is always interesting to study because here you can really nicely see disease variability in a larger population of patients with the same identical disease-causing mutation. For MAC1, it's very different. There you don't see missense mutations. You have instead this very complicated variant number tandem repeat, that is a repetitive region of the gene with 60 nucleotide repeats and very much GC rich, which makes it difficult to sequence. And that's also why it's impossible to deal with conventional exome sequencing and to detect VNTR alterations in the conventional short read exomes. I should say short read because with long read it's different. And that's also why the the detection is only possible with specific genetic methodology, and I will get to this later. But what is disease causing is a typical insertion of a cytosine in the variable number tandem repeat, and this causes the frame shift of the protein. There's some reports of earlier frame shift or earlier insertions here, but usually it's an insertion of a C within the VNTR. And this neoprotein, the MAC1 frameshift protein, then causes the cellular toxic gain of function defect. When you look at the genotype-phenotype analysis of the initial study by the Swiss Belgian registry and the US registry, you see first of all that UMOD positive patients and UMOD negative patients are distinct from each other. So UMOD positive here was associated with earlier ESKD and notably earlier gout. But what is more interesting is the comparison with UMOD positive and MAC1 positive. And you see that overall renal survival is a little bit worse in MAC1 disease. So with a median of 46 years of age, compared to ADTKD UMOD with a median of 45 or 54 years of age. So MAC1 tends to be more severe overall, but strikingly gout, early onset gout, is much more associated with ADTKD UMOD and not so much with ADTKD MAC1. As you know, gout is also a frequent phenomenon in the general population. But early onset gout is really something that is associated with ADTKD UMOD. The reason for early onset gout is thought to be due to the low fractional excretion of uric acid in these patients. So observations from the from earlier studies made that the urinary uric acid excretion is reduced, and that's why uric acid is elevated already with normal kidney function. So that's the susceptibility, or that drives the susceptibility to early onset gout in these families. The appearance of cysts is not pathognomonic to the disease, so you can have single or also bilateral little cysts, but it's not needed for the diagnosis, and it's definitely just a side criterion. In the systematic analysis, here you see that only a minority of patients even had cysts, both in ADTKD UMOD and ADTKD MAC1. And this study from 2014 nicely illustrates the intrafamilial variability. Age of ESKD or ESRD is seen here on the y-axis, and you have the families on the x-axis, and you see each dot represents an individual, and you see families with a lot of affecteds here still have very variable renal survival. So reaching from 80 years of age, and then one individual with like mid-20s. So that's very vexing, and that's still not well explained in our understanding of the disease. And Christian nicely illustrated the pedigree from his family, where we also see this discrepancy within different family members. So there is for sure mutation independent factors, because in the family there is the same mutation ongoing. So there could be genetic background, could be environmental factors, exposure, and so on. But when you think of the differences between different families, there's also some kind of mutation dependent factors. And we know that some variants in ADTKD UMOD are more severe overall, and others are associated with a less severe course of disease. And there's studies that also analyzed whether there is some kind of in vitro scoring, and this is a very nice work from Anthony Layer's group, where they did in vitro scoring by Western blotting, And you know, UMOD, I've already mentioned that in the beginning, is basically processed by the ER, by the Golgi, on its way to the plasma membrane, and it undergoes maturation by glycosylation. And the retained UMOD, therefore, has a lower band than the mature UMOD that you would expect in the wild type situation. And so in vitro experiments were used here to score the disease severity based on the maturation of UMOD, and the work nicely shows that this maturation of UMOD actually associates with disease severity in terms of age at ESKD and renal survival. And other factors that are important to take into account are male gender. We know that from ADTKD as well that male gender and other kidney diseases is associated with more severe causes, and also parental age of ASKD, of course, and notably the maternal age of ASKD. This work by Eric Ollinger and Olivier Debreist 2 years ago nicely illustrates the rather mild spectrum of UMOD variants. So this UMOD variant T62P is a rather frequent variant that is on the brink to a common variant. It's 1 to 1,000 in European individuals. And this UMOD variant, and this nicely showed that in this publication in PNAS at the time, is associated with susceptibility for kidney failure, median at 74, but it's by far not as severe as the canonical UMOD mutations with a median renal survival of 54. And you see here, when you look at, they also analyzed this on a functional level by stainings and also by UMOD maturation, that this nicely correlates with the degree of UMOD maturation and is kind of more of a risk allele than a truly Mendelian UMOD alteration. Shortly coming to HNF1 beta, as this is always controversial in the ADTKD field. So HNF1 beta is a transcription factor that is associated with lots of different phenotypes, with lots of different clinical syndromes. I already mentioned maturity onset diabetes of the young is involved due to pancreatic hypoplasia. There's genital tract malformations, neurological features, notably if you have a larger microdeletion syndrome that is called 17q12, and HNF1 beta lies within this large deletion, abnormal liver function and developmental kidney disease, and alterations of the electrolytes like hypomagnesemia and gout. But what we mean with HNF1 beta ADTKD is rather an adult onset mild form of disease with less extrarenal manifestations and a positive family history. In this classic HNF1 beta families, oftentimes it's de novo, these large deletions are de novo, and oftentimes it's more a congenital presentation, and that's not what was originally meant by ADTKD HNF1 beta. That's why we think that the presentations as isolated ADTKD are rare, and they for sure have to be better defined. A short word on ADTKD-REN, which is the gene encoding the pre-prorenin, which is important for blood pressure regulation, as you all know. There is nice work from Martina Sivna from the Czech Republic, where they analyzed the functional effects of different REN variants. And this is one of the disorders where there's evidence for genotype-phenotype correlations that nicely match with the spot of the mutation. So you can discern mature protein mutations, which are in the C-terminus, from pro-segment mutation and signal peptide mutations. And it has been shown that individuals with mature protein mutations have less severe phenotypes, almost no childhood anemia, which is normally associated with ADTKD-REN, and a better kidney survival all over. Whereas the signal peptide families, they are rather affected by childhood anemia, early onset anemia, far before CKD is starting, and then also a less great kidney survival, but kidney survival at a median age of 57. So it's rather in midlife, late adulthood. Regarding the diagnostics, this is almost outdated because you've already seen the start of this flow chart, but when you come to the suspicion of ADTKD, then the question is, do you do next generation sequencing in terms of exome, genome? Do you target it? What do you do actually? And how do you tackle the difficulties with MAC1, which needs a specific genetic diagnostic? So I would come to the gold standard of MAC1 diagnostic directly, because as you have heard, short reads NGS techniques are not validated or have been always problematic for the detection of the VNTR duplication. Therefore, the gold standard is still the snapshot mini sequencing, and that is a technique that is quite costly, where you have nucleotide fluorescently labeled nucleotides, and in the wild type situation, you would have a distinctive pattern. After the repetitive Cs, you have the first adenine that is causes this peak, and when you have an insertion of cytosine, then you would have a distinctive pattern that is different from the wild type. And by this, you could make the diagnosis of a duplication in the VNTR. However, what we have since last year's publication at least is a tool that is called VNtyper, and this tool is a bioinformatic tool that was first published by the group of Corinna Antignac and Guillaume Dorval in Paris, and the authors here, they proposed an alignment-free VNTR genotyping using short-read sequencing data, so data from standard panel or exome sequencing with short-read sequencing reads, like a standard Illumina exome, for instance. And when you do this, you can try to map the VNTR region and then come up with a bioinformatic prediction of a VNTR in double insertion of cytosine. And this tool turned out to be pretty good at the time in predicting, it's a screening tool, so in predicting an insertion of a C in the VNTR. And so it was proposed as a screening tool to then choose patients for snapshot validation. And what has been going on since then is that some groups, like the one from Laurent Mesnin in Paris, but also ourselves, we started to making this VNtyper more accessible, reducing the runtime, and making it more accessible also to users that are non-bioinformatics. So, but this publication just came out a couple of weeks ago from Laurent Mesnin, where he introduced his version of the VNtyper. It's a modification called Shark VNtyper, and where he was able to reduce the runtime of the tool, and he was able to show that 32 out of 33 patients with previously identified MAC1 variants were correctly identified. So he had a quite high sensitivity, and he also ran patients that were MAC1 negative by snapshot and could show that these stayed negative, so coming up with some kind of a specificity. And we are also now in the process of using our consortium that I will introduce in a minute to do a similar approach on a larger scale with a more accessible tool that is meant to be used for the public. So ideally, what you would do nowadays in a diagnostic setting, you would run the usual short-read sequencing, NGS, but you would make sure that you spike in different enrichment methods to cover complex regions, right? So like MAC1 like PKD1. And this is called clinically enhanced exome sequencing. You would also make sure to cover the mitochondrial DNA, and then you could use the data to run VNtyper as a bioinformatic tool in every clinically enhanced exome. So that would allow to have in the standard diagnostic setting to have both UMAT but also MAC1 in there for screening. And then if MAC1 is if MAC1 VNtyper for MAC1 is positive, you would still need the mini sequencing approach for validation. Differential diagnoses of ADTKD are, of course, nephronophthisis as the recessive kind of the recessive version I was about to say, but yeah, nephronophthisis is most of the time more of a syndromic disease. You may have known that's more of, as it's a ciliopathy, it's most of the time associated with a lot of extrarenal manifestations. There is isolated kidney disease in NPHP1, but still it's not associated with a dominant pedigree and not associated with for parents that are affected. Then there's atypical forms of ADPKD, like DNA JB11 disease that kind of could resemble ADTKD with few cysts and more interstitial fibrosis. Mitochondrial diseases are a differential diagnosis, and they often cause tubular interstitial disease, and others like FAN1, which is a distinct form of interstitial nephritis with morphological changes of the nuclei and the tubular epithelium. Regarding ADTKD therapies, there is no specific therapy available to date. We treat just supportively by avoidance of nephrotoxins, avoidance of dehydration, avoidance of infections. We would in ADTKD UMOD start uric acid lowering drugs once there is a high likelihood of gout, like with very high uric acid levels. Kidney replacement therapy is curative. There's no risk of recurrence. And the often raised question whether there is any role of SGLT2 inhibitors or RAS inhibitors beyond blood pressure control, well, that's not analyzed in any randomized controlled trial. There's like very more anecdotal evidence that SGLT2 may even be harmful, but there's no clear evidence to date. And so in tubular interstitial diseases, the role of SGLT2 anyway is not established, so I wouldn't use it in the current situation. RAS inhibitors we sometimes need for blood pressure control, of course, and of course the situation is different if there's more proteinuria. And then there is small molecules and hopefully gene therapy on the horizons. Regarding small molecules, I will come to this in a minute. So first of all, the few studies on ADTKD after transplantation didn't show any difference between ADTKD transplant survival and other kidney diseases. The extrarenal complications like gout remain, of course, a risk even after transplantation, but otherwise the disease doesn't recur. And regarding the small molecules, there was the seminal work by Anna Grecker's group 5 years ago now, where they identified a compound in a drug library screen. It's called BRD 4780, and this compound was able to remove mutant MAC1 neoprotein both in an animal model and in a human iPSC-derived kidney organoid model. And of course, it was a huge hope that this could find its way to a clinical trial, but due to toxicity issues, the clinical trial has not been implemented yet. On the other hand, the same molecule was also shown now to be effective in ADTKD UMOD, also by Anna Grecker's group, first also Silvana Basua. This work is in press. It's not out yet at JCI, but will appear very soon. And here also they used this compound in treating a UMOD mouse model, missense mouse model, and same as in the MAC1 story, kidney organoids. But as I said, this compound, in the way it is like now, will probably not be used for clinical trials due to toxicity issues. The group of Olivier de Weust has investigated differential effects of different UMOD missense mutations. So as I told you, there's mutations that are associated with rather mild cause, like the cysteine 170 tyrosine, and on the other hand, the arginine 185 serine mutation is much more severe. So the colleagues created mouse models for each of these ADTKD UMOD mutations and analyzed different mechanisms. And indeed, they found out that in the mild form, there's still soluble UMOD being produced and in part also being released. Whereas in the more severe form, there is a very strong aggregation of UMOD and a more pronounced toxic gain of function effect. And if you enhance autophagy by inhibition of mTOR, that could clear the uromodeline aggregates, and autophagy enhancement may be another way to tackle the disease. And that was also described in this very recent publication where they identified a protein called MAMF, mesenchyphalic astrocyte-derived neurotropic factor. And this MAMF boosting reduced the ER stress and could indeed clear some of the uromodeline aggregations and the downstream dysfunctions that were associated with UMOD disease in their model. As a new gene of ADTKD, I told you that there is a large proportion of ADTKD NOS, not otherwise specified. A new gene was reported last year by Anthony Blair's group in Wake Forest, US. This is ApoA4, and ApoA4 is actually associated with not only tubulointerstitial fibrosis phenotype, but also with medullary amyloidosis. So in addition to the normal fibrosis, they also saw Congo red positive fibrosis areas upon kidney biopsy. And they identified 5 families with ApoA4 missense variations that were actually shown to be pathogenic. And this is, I think, an interesting but very rare subtype of ADTKD-like disease. In the last year, so in early 2024, this group convened for the first time. It's a new ADTKD consortium on the European level, ADTKD-net. It's coordinated by Charité, and it goes back to funding by the European Union from the European Joint Program on Rare Diseases. And the aim of this collaboration is to actually come up with a description of the natural cause of disease and then a better understanding of the risk factors that contribute to more severe disease versus mild disease. And to achieve this, this group will now establish an ERKNet-based sub-registry. So you know, in the ERKNet registry, there is sub-registries that deal with certain diseases. And the sub-registry is currently being programmed and is probably going to be effective early 2025. This group here will also do decentral but streamlined biobanking for patients that get enrolled. And we want to work very strongly on the implementation of the VNtyper 2.0, so this new accessible form of bioinformatic analysis of short-read sequencing data to really detect as many ADTKD MAC1 cases as possible. So I conclude, coming to the take-home messages, ADTKD is an unspecific clinical presentation. It's probably underdiagnosed, and we need genetic testing for its diagnostic assertion. ADTKD, UMOD, and MAG1 are the most common subtypes, and together they contribute for at least 0.5% of all ESKD patients. Mechanistically, it is a toxic gain-of-function disease, and remember that there is retention of a protein that somehow aggregates in the ERKNet. Generally more severe kidney disease in MAG1 compared to UMOD, but more prevalent gout in ADTKD UMOD. There's very much variability in disease progression, which we not fully understand to date. Role of male gender, of genetic modifiers, of environmental modifiers. And we know some genotype-phenotype correlations already, but there's still a long way to understand why there is so much variability even within families. For MAG1, VNTR needs specific, the VNTR duplication needs specific genetic techniques like mini snapshot read sequencing, but there is a diagnostic breakthrough due to the VN-typer, which is now being implemented on a wider level. HNF1-beta is, as I told you briefly, there's consensus that there is no consensus basically, so we need to better precise or better define what is meant by ADTKD HNF1-beta. For ADTKD REN and SEC61, this is rare forms that are not fully understood, but for REN we do know that the variants correlate with the phenotype severity in a way. Unfortunately, we do not have specific therapy to date, but we are hopeful that this is going to change in the near future, and one of the steps to achieve trial readiness, as we always call it, is the new European consortium on ADTKD, ADTKD-net, with its sub-registry in ERKNet, and look out for the launch next year. And we would be very much, we would be happy if everyone who is taking care of patients with ADTKD would be willing to register as patients in this web tool. And thereby I close my presentation and would like to thank all collaborators in this consortium and you for your attention. Thank you very much.
Thank you very much to you both, Christian and Jan, for this fantastic presentation. Very interesting news indeed, and very structured. I personally did one major mistake in the beginning. I did not tell you guys to put your questions in the question box, but in the meanwhile, I at least received 4 questions, which I would like to launch. And the first one is, I think you had the information in your talk already, is about treatment possibilities. And it's a question by Abdelhamid Hamdi Ramdan, who asks whether ACE inhibitors, SGLT2 inhibitors, and allopurinol are part of, or could be part of the treatment. And later on, he precised his question once more and asked why SGLT2 inhibitors may be harmful in the setting of ADTKD.
I mean, this is speculation, of course, but it could be that the glucosuria or the glucose content in the urine is not ideal for tubular disorders like ADTKD. But we don't know whether it's harmful. It's based on n equals 10 small case series, like patients in small case series. So I would be very cautious with the term harmful. But on the other hand, I don't prescribe it to my patients right now because I think it's not well justified.
All right.
I could give a short answer if
oh,
required.
absolutely.
We had this question in our family too, and my daughter took it firstly. We discussed that with Tony Blyer, mentioned also by Jan already. And the point is that the creatinine value jumps up immediately. So there's also a psychological effect. You know, patients who are looking for the creatinine level with fear, that is always difficult if you take a medicine and then it jumps up additionally, which is supposed to be an effect of SGLT2. And so both my wife and my daughter don't take it anymore.
Yeah, that's.
I mean, there's the hemodynamic effect we know very well, but beyond that, I think we need to set up an RCT to answer that question, because unless there has been a nicely set up study giving placebo versus SGLT2, this will always remain kind of an area of uncertainty.
But indeed, a very important comment by you, Christian, because when you think about that treatment, you should discuss that point with your patients in advance, that you would expect the creatinine levels to go up. Indeed, yeah.
And additionally, I think Tony Blyer also changed his mind. I think, or he wasn't never sure. 2 years ago, I think he recommended it to my knowledge, and then he wasn't sure anymore. So it's real unclear, and yeah, but as I said, the most effect is that the creatinine increases, and this is, I can really understand that for patients this is really, really difficult then.
Mm-hmm. Then there's another question by Anna Dovch, I hope I pronounce it correctly, and she's asking whether a prophylactic treatment with urate lowering therapy is required after transplantation or only if gout recurs.
Yeah, we don't do it as a prophylactic treatment. So we just go by, so if there has a long-standing history of repetitive gout episodes and high levels of uric acid, we would rather initiate it, but it's really on an individualized basis. And we wouldn't use it automatically on a prophylactic level.
Okay. Then I have another question and a comment first by Jessica Kachma, who's extremely happy with that talk and is one of many here in the audience. She has heard that some physicians give vitamin D for ADTKD subtype MAC1 due to previous evidence that high doses might lower MAC1 expression. Is there any recent evidence about this, and what do you personally think about this?
I don't have, I'm not aware of robust evidence that this is indicated, so I wouldn't do it differently than in any other CKD patient, to be honest. I would go with the vitamin D levels, with you know, risk factors for bone disease, fractures, and so on. But I wouldn't give it on a prophylactic basis. Again, I think not enough evidence here. And when you think of the downsides of vitamin D administrations, like calcification, nephrocalcinosis, and so on, I think we may be cautious here as well.
Then I have the last question here from the question box. No, not the last, but another question from the question box. Should patients with ADTKD be screened, to be generally screened for diabetes mellitus or MODY diabetes? I think that's easy.
No.
Not generally.
And no. Which was HNF on beta, you mean?
Yeah, that's not mentioned, but I guess that's the question. Yes.
Yeah. Okay. If there's HNF and beta, of course, they need to be screened, but not not the other ADTKD subtypes. Sorry, I didn't get that. But HNF and beta, you need to screen for diabetes mellitus, of course.
Yeah. There's another, maybe we can make that clear again and point that out clearly again. There's another question from Xiang Hua, who asks why patients with ADTKD have a great effect after transplantations and symptoms usually do not come back through the mutation still exists. So that's what you pointed out, that actually after transplantation you have no recurrence of the disease. Yeah, okay.
Maybe also here one small comment, if that's possible.
Absolutely.
Yeah. So when we got these diagnosis about ADTKD, I recall that the nephrologist, it was a woman, I can't recall the name anymore, told our family that ADTKD among all diseases is a better disease. And at that time, we didn't really understand. But now having contact to other patients, in particular PKD patients, where the kidney really is enlarged and the liver is infected, ADTKD is really has less side effects, and we understand that it's really a better kind of disease. Still, it's not treated, but you have several advantages, so to speak, compared to other diseases. That's what I learned personally 4 years ago. 4 years ago, we didn't understand what she meant to us, but when I see other patients with more severe problems, also the question of coming back on the transplant, yeah, I understand the phrase, it's a better disease among the diseases. Just as a comment.
Yeah, I personally find it hard to compare diseases. You will always find somebody who's worse, but it's hard enough still when you're affected. And actually, that's my maybe last personal question, because I was thinking about your daughter all the time, Christian. You shared that in the very beginning, that when you see these Kaplan-Meier survival curves, it's hard to find the case of your daughter. And I personally, just a few weeks, unfortunately, identified a patient and could identify the MUC1 mutation of her father as well, who started dialysis when he was 26, but she is 11 right now, and she's close to dialysis. And I'm wondering, are there any ideas like genetic modifiers or whatever, Jan, that you have, why these huge intrafamiliar variability is such a problem?
Yeah, in this in this specific situation, I don't know really, because I don't want to speculate too much, but I think we definitely there's certain indications, like, you know, in UMOD, for instance, we have a lot of common SNPs, SNPs in the promoter region, for instance, SNPs that may affect UMOD expression, either in an upregulation or downregulation. And this could be one answer for, at least for the disease variability in ADTKD UMOD, as it's very well known that UMOD promoter mutations are a very common phenomenon and are associated with CKD variability itself, you know, completely separate from the Mendelian ADTKD UMOD story.
All right, thank you very much for that. I don't see any further questions in the question box. I would like to ask Christian if there's anything he likes to add to what Jan said.
I mean, of course, we as a patients, finally, we all do this for getting treatment in some years, and I just can repeat, finding patients, I think, and increasing awareness of ADTKD is the thing we can do. And of course, Jens, it was a hard news when we got the news 4 years ago about the disease. But doing this work here with ERKNet, and I'm very thankful to ERKNet, is some kind of therapy for us, of course, to work on. And we have a second daughter, which has no test so far. And yeah, of course, we are in the hope of a treatment in, I don't know, 5 years, maybe, Jan, 10 years. Probably it's difficult to say. Yeah, that's why we are working for it. That's that we finally get a treatment in the near future.
Yes, that is a very nice conclusion, and to point out the motivation of us all who are actually involved in ERKNet. Thank you very much for that. And as there are no more questions in the question box, I would again like to thank you both for that fantastic presentation. And we would like to end by pointing out the next two webinars that will be on the 19th and 26th of November. The first you see will be the highlights from the KDIGO clinical practice guideline on AD. Now it's ADP, sorry, I should pronounce the P, ADTKD, the polycystic kidney disease, presented by Olivier de Voist, and CKD mineral and bone disorders after transplantation, presented by Agnieszka Brytula-Ebels from Ghent. I think this is the end then. Thank you for your attention. Thank you for your question and discussing, and I hope to see you back next week then. Thank you very much.
Thank you.
Bye. Thank you.
Bye.